If you've been told diverticulitis always follows the same playbook, there's a good chance that you've been given an interpretation that no longer matches how this condition is understood today. Treatment has evolved, and that leaves a lot of people unsure what still applies, what doesn't, and what actually matters now. I'm Dr. Kenny Middlestat, an IFM certified functional medicine practitioner, and I help people think through complex chronic digestive issues just like this. And in this video, we're walking through how diverticulitis is treated today so that you can understand the current landscape, the best available research before making decisions. Let's start with what has actually changed. If you've ever been told that diverticulitis automatically means antibiotics, imaging, and a very specific set of steps every time, the approach is starting to shift. And that shift, of course, fosters along with it a lot of confusion along the way. On the one hand, people are still being told you need antibiotics right away, no matter what. On the other hand, they're hearing maybe you don't. If you're getting completely different recommendations for the same diagnosis, that's not random. It usually means that the condition is being interpreted differently and that the research is evolving. So what changed? Over the past decade, researchers started asking a simple and important question. What if not every case of diverticulitis is driven primarily by an infection? A large systematic review published in 2023 compared antibiotics to supportive care. And this was done in uncomplicated cases. And what they found was significant, that outcomes like recovery time, complications, and even recurrence were very similar between the two groups, no matter what approach you took. Most people hear that and they assume the treatment changed in some way. But what actually changed was how we interpret and address the condition itself. This doesn't mean that antibiotics aren't potentially useful in some cases. It means that they're no longer automatic. That's the nuance that is shifting. And that's a very different way of thinking. Instead of following a fixed protocol, because we've always done it that way, quote unquote, treatment is becoming more selective, more dependent on individual patterns in front of the practitioner, rather than just the diagnosis itself. If antibiotics and the infectious origins aren't automatic or always necessary, what's actually driving the inflammation associated with a diverticulitis flare in the first place? One of the biggest misunderstandings around diverticulitis is that it gets treated like an all or nothing black and white infection story, as if every flare for every person means the same thing. Bacteria showed up and maybe caused a problem, now the goal is to eliminate it. But that model behind what drives diverticulitis is probably too simple based on our research. Diverticulitis can involve infection, but it also involves inflammation, perhaps more importantly so. And those are not always happening in the same proportion or behaving the same way in each person from person to person. This is where many people start to notice a mismatch between what they were told and what they've actually experienced with diverticulitis flares. Most people are not dealing with the same kind of flare each time even. They're just being spoken to as if they are. And once that assumption is in place, the treatment conversation becomes oversimplified in a way that doesn't match the underlying function or physiology. In fact, a 2023 systematic review looking at the microbiome in diverticular disease found recurring shifts in the gut environment. They narrowed in on a particular group of species in the microbiome and looked at lower levels of butyrate producing bacteria. Butyrate is a compound that your gut bacteria produce from fiber. They turn fiber into anti-inflammatory fats, and it helps to regulate and support the cells and repair process along your digestive tract and colon. What this suggests is that for some people in diverticulitis is that the colon environment is already potentially more vulnerable to inflammation. It's more reactive, it's less resilient before the flare even happens. Diverticulitis stops looking like this single event and starts looking like a pattern that is expressing itself across systems, thus systems-based functional medicine. Once you see that and we start to reframe it as an inflammatory and resilience conversation, it's much less about the bacteria itself. And so if the infection component in some people and the inflammation component are not interchangeable, then the treatment can't be either. And by the way, if you're one who enjoys seeing the research for yourself, I've included a free research summary that includes some of the links that I used for this particular video. Check it out. It's in the pinned comment in the description below. Once we take a step out of this black and white reductionist thinking, the next question becomes more practical. How do you actually decide what to do for each specific person and case? The answer is clouded because sometimes the wrong lens is used to make the decision. Instead of asking, is diverticulitis present or not? The more useful question here becomes, what kind of pattern is showing up in this expression of diverticulitis? This is where the treatment and the diagnostics become context dependent. Some flares lean more toward the infection component. You might see worsening symptoms, more systemic signs like fever and chills, or a clinical picture where antibiotics clearly make sense. Other flares look different, maybe more localized, more inflammation-driven, more consistent with a reactive gut environment rather than this dominant infectious factor. In those cases, the diverticulitis may resolve the flare with supportive care alone. And that's the shift. It's not removing the tools, but matching the tool to the individual's pattern. Because when every flare is treated the same way, the assumption is that every flare is also created the same way. Clinically, that's just not what we see. And when we look at what layers underneath diverticulitis, we know those inflammatory and resilience components matter a bunch too. This is where the conversation begins to land for some people a bit differently. Because for a lot of people who experience diverticulitis, the issue isn't just getting over one flare. It's getting through one and then realizing and not fully trusting that it's over. That uncertainty tends to stay in the background. And now we're talking about recurrence. The frustration usually isn't the flare itself, but it's the sense that no one clearly explained why it happened and why it keeps happening. This is where the purely short-term treatment or management mindset starts to break down. And we can see this in many other chronic conditions. Even if the initial inflammation settles, the conditions that allowed it to occur may not have changed when we talk about the microbiome and the resilience factors. In recurrent cases, the question starts to shift from not just what calmed this down the last time, but what keeps setting the stage for this diverticulitis to happen again. That's where certain patterns start to show up more consistently. You may see unresolved stress chemistry, where the nervous system remains in a more reactive, pro-inflammatory state. You may see more widespread microbiome imbalances, or even hidden parasitic infections, or opportunistic overgrowths, or yeast, for instance. You may also see more broadly weakened immune system. Do you also suffer from allergies, or do you get sick every time a cold gets passed around? Our gut represents an important part of our defense system body-wide, not just related to GI or gastrointestinal symptoms. The big takeaway here is that even if a flare resolves, the environment itself may be staying the same. And that's the most important functional driver. When your environmental factors stay vulnerable to the development of diverticulitis, it doesn't take much to repeat the cycle. This is where a systems-based functional lens tends to widen the picture. The inflammation may be showing up in one part of the body, the colon, for instance, but that doesn't mean that the cause is limited to that location. What's happening locally is often influenced by systems operating more broadly across the body. Everything is connected. A few of these connections tend to show up repeatedly. The nervous system matters because stress physiology changes motility and blood flow, and also the immune coordination in the gut and body-wide. The microbiome matters because it modulates the inflammatory and anti-inflammatory tone in the colon, and the integrity of your immune barrier and interface in the gut matters because the lining is constantly deciding what gets tolerated and what gets treated as a threat, thus mounting an inflammatory response. This is the part that most treatment approaches, especially in acute management of diverticulitis, never fully account for, but it often determines how the condition behaves over time. Then there's the broader inflammatory context. A 2023 cohort study found that obesity was associated with a higher risk of diverticulitis. not as a single cause, this and that, but as part of a larger pattern. What we know about obesity is that it is a chronic inflammatory condition. The baseline metabolic and inflammatory environment influences how the colon cells respond as well. In practical terms, this just means that diverticulitis is not always just a little pocket in the colon problem. Sometimes it reflects a system that's already more reactive and less resilient. And if that's the case, focusing on just the local inflammation may not fully explain why the flare happened once again, or why it keeps happening. So let's come back to the antibiotics discussion, because this is where nuance does become important. The takeaway is not that antibiotics are bad, and it's not that they should never be used. They can be incredibly important, powerful tools and a marvel of modern medicine. The problem is not the tool itself. It's when the tool is used without understanding the pattern and honoring the nuance. In complicated diverticulitis, in people who are immunocompromised, or in cases where symptoms are worsening instead of settling and following a resolution trajectory on their own, antibiotics can absolutely be the right call. And this goes alongside best practices. But the key word there is a tool, not a reflex, not a rule. Once you understand that diverticulitis can sit on a spectrum between infection and inflammation, the question becomes, how severe is it? What are the risks that are present around this situation? And what does the system appear capable of handling in this individual, in this snapshot in time? Because another layer worth keeping in mind is that though antibiotics do help with the infection when it's part of the picture, they also can shift the microbiome in long ways, sometimes for years down the road. That matters, especially someone who's already prone to recurrence. So responsibly addressing infection versus inflammation is all about balance and discernment and good triage and good doctoring. Use the tool when it fits the pattern, but don't assume that the tool explains the entire condition. If this gets boiled down into one major shift in thinking, it's this. Diverticulitis treatment is evolving because the condition is being understood differently in the context of what drives diverticulitis in the first place. Not because the old tools have necessarily stopped working, but because they were often applied as if every case followed the exact same pattern, the black and white world of diagnosis. But what's becoming clearer is that diverticulitis is not purely structural and it's not purely infectious. It's often a pattern that emerges when local vulnerability and broader systems stress overlap. It's not just structural. The diverticule alone do not create the inflammation. It's not just infection because flares don't behave uniformly. When you see that there is systems overlap instead, local vulnerability and loss of resilience, the inflammatory tone, microbiome shifts, immune signaling and regulation, nervous system input, and even the metabolic context, all interacting together, it really honors the complexity of our human function. A flare is what gets your attention, but it's rarely where the process starts. Most people focus on the flare itself when it happens, which of course is important to manage, but we're maybe not seeing what made it possible. One of the more useful questions on the other side of this becomes, why does one person live with diverticulosis before it becomes inflammatory for years without issue, while another keeps returning to the inflammatory state and flare? That difference isn't explained by the diagnosis alone. It's often shaped by the underlying terrain that we talked about, how the gut regulates inflammation, responds, and recovers over time. This next video over here walks through that barrier and what determines whether the gut stays more stable or becomes reactive. I'm Dr. Kenny, Root Cause Health Detective. Thank you for watching, and I'll see you in the next video.